afternoon and good evening, everyone. Welcome to East Meets webinar series supported by Samsung. My name is Wonchol Bang, Vice President of R&D in Samsung Healthcare. I would like to thank Imperial College Consultants and two co-moderators of today's webinar, Professor Christopher Lees and Professor Mauro Cristian Parra, for bringing together the world experts to today's webinar, Ultrasound in the Labor Room, Why, How, and When. I'm very happy to share with you today. This webinar will be provided with Spanish subtitles. The speakers for today's webinars are Dr. Larry Hinkson from Germany, Professor Minjung Oh from Korea, Professor Torbjørn Moe-Gebo from Norway, Professor Andrea Dall'Asta from Italy. I hope that this webinar enables you to broaden your horizons about basic and more advanced techniques of ultrasound in labor, why they are performed, and what they mean. And during and at the end of the webinar, we would appreciate it if you could take part in the survey and share your thoughts. We promise to provide better webinars next time. Thank you very much, everyone. And let me hand over to Professor Christopher Lees. Professor Lees.
Okay, thank you very much indeed for that introduction. So I'm looking forward very much to this webinar. Ultrasound in the labor room has become a really important part of the practice, for instance, my obstetric practice, and for many of us. But actually for very many obstetricians around the world, ultrasound in labor is not a basic part of their practice, and actually can be a bit daunting, a bit scary, not quite sure how to measure things, why we do things in a certain way. And it's important to note this is quite a new technique, 10, 15 years old really, where we've been describing the methodologies for ultrasound in labor. And we've got an all-star cast from Scandinavia, from Europe, and from South Korea as well, to discuss how we might do these ultrasound measurements, how they fit into our practice, why they're important. And we want to hear from you as well, so there's plenty of time for questions too. So I'm going to stop talking there. I'm going to introduce each speaker as we go, and I'm co-chairing with Professor Mauro Parra, my good old friend and colleague from Santiago in Chile, who is going to help with some of the questions and comments we may get from our Spanish-speaking attendees, which is, I think, going to be great and really useful. At these webinars, traditionally, we have quite a number of delegates from South American countries and Spain, so it'll be really wonderful to be able to interact properly with them, with Mauro helping to translate and interpret. I'm going to hand over to Mauro now, and then I'll introduce Larry Hinkson, our first speaker. I think we've lost Mauro. So it's two minutes into our webinar. We've lost our co-chair. I'm sure he will come back in a moment. I think what we'll do is we'll move straight on to Dr. Hinkson from the Charité in Berlin. Larry is an absolute expert in ultrasound in labor and has some particularly interesting concepts about how its use is helpful in assisted delivery. And of course, this is very important area because we all want to make sure that if we use forceps, they're applied correctly. If we use Von-2s, that's in the correct position. So, Larry, I think we'll go straight to your talk. Hopefully, we'll reconnect with Mauro Parra a little bit later.
Hi, my name's Larry Hinkson. I'm the lead obstetric consultant working at the Charité University Hospital in Berlin in Germany. I'm very happy to be with you today at the webinar to share my experience with ultrasound and assisted operative vaginal deliveries. I always like to start my presentation with this slide, and it's taken from the story, The Little Prince. And the story goes, he draws a drawing and shows it to the adults around him, and he asks them if they are frightened or scared. And they reply, why should we be afraid of a hat? You know, it's just a hat. You put it on your head. It's nothing to be afraid of. And then he goes on to explain, well, you know, it's not actually a hat, it's a snake, a big snake, a boa constrictor, and it just swallowed an elephant. And it's a funny little story, but I think it reflects some of the situations that we're confronted with in labor ward. When we do clinical examinations, we think we know what we see, and in the reality, it's sometimes an illusion, and our clinical examinations are wrong. And there's a lot of work that's been done by Akmal, Dupuy, Molina, Nicolaides, who've shown that in up to, incredibly, 80% of our clinical examinations are sometimes wrong or false. And this can have severe implications, especially for instrumental deliveries, such as forceps and vacuum. Now, the indications for these instrumental deliveries are varied. There could be fetal reasons, maternal reasons. For forceps, particularly for preterm deliveries, less than 32 weeks in particular, and in seldom cases for the aftercoming head at breech delivery. Of course, we are concerned about maternal and fetal risks, and we have a vast array of instruments at our disposal that we can use for the indication of assisted vaginal delivery. Now, we do perform actually a lot of instrumental deliveries. If you look at the data coming out of England 2019, there was a 5% incidence of vacuum delivery and an even higher incidence of forceps deliveries, 7.3%, and that's a total of 46,000 forceps deliveries in 1 year. Across the pond in the USA, in 2016, almost 250,000 forceps deliveries were performed. Now, this is a large number, and I think our duty is to try and find a way to perform these instrumental deliveries as safely as we can and as effectively as we can with the minimal damage to mother and babies. One of the most important things about vacuum deliveries is identifying the flexion point on the fetal head on which to apply the vacuum cup, especially in occiput posterior positions. And here you can see in this demonstration, it's a case of a woman with a prolonged second stage of over 3.5 hours, and the delivery is being performed in operating theater. An episiotomy is being performed to create more space and to protect the perineum. And the suction cup is a metal cup that has been applied, and traction forces are now being applied in synchrony with the maternal contractions and pushing. And you can see the perineum is now being supported, and the direction of traction is in line with the birth canal, at first downwards and then upwards above and across the symphysis pubis, and then the head is delivered. And if you notice, the position of the cup is actually on the anterior fontanelle, which is not the flexion point. The flexion point is 2 to 3 centimeters behind the anterior fontanelle. And in these scenarios, you can appreciate the increased incidence of cephal hematomas and intracranial bleeding because there is no skull bone in the anterior fontanelle protecting the brain, protecting the blood vessels beneath. Similarly, for forceps delivery, you need to be anatomically 100% sure of the position of the fetal head in the pelvis, even before you start to apply the forceps blades. And in this case, the left blade is being applied firstly, followed by the right blade in a position of anterior occiput, in a case where the woman was in 33 weeks of pregnancy and came with a pathological CTG and a fully dilated cervix. Now, in 2006, it was a rainy night at the Charité University Hospital, and Professor Wolfgang Henrich was on call, and he was examining a woman with a prolonged second stage of labor. And he used the ultrasound scan, and the ultrasound transducer went further down between the transperineal region, and he was able to achieve ultrasound picture of the movement of the fetal head in the maternal pelvis. And this was the first photo documentation that was published, and he described it along with Boris Tuchek as the head-up sign. And since this paper was published, there has been an exponential rise in the research papers done on ultrasound and labor, with over 44,000 publications since that time. Important landmarks to recognize with translabial ultrasound are the symphysis pubis and the fetal skull. And you can appreciate that here in this diagram, the fetal skull and the symphysis pubis. Now, if you draw a perpendicular line from the edge of the bottom edge of the symphysis pubis, we call that the infrapubic line. And we know anatomically that a parallel line 3 centimeters caudal is the interspinal line. And this has been proven in MRI studies to compare the two parameters. Other ultrasound parameters that we have discovered include the angle of descent or angle of progression, which is a line drawn horizontally through the symphysis pubis to meet the line coming from the leading edge of the fetal skull to the bottom end of the symphysis pubis. This is called the angle of progression. These parameters have been shown to be simple and reliable to reproduce, regardless of the ultrasound expertise of the person performing them. Professor Boris Tuchek went on even further to find a correlation between the angle of progression and the head station. And this is particularly important when you're doing instrumental deliveries. You want the head to be below the spines, or at least in the mid-cavity of the pelvis. And he made a nice chart to demonstrate the correlation of angle of progression degrees and the head station. Now, can we use angle of progression to predict the mode of delivery? Well, in a study done by Professor Kalash and Professor Dudenhausen at the Charité, they showed that the chance of successful vacuum delivery was over 90% if you have an angle of progression of more than 137 degrees. There have been, over the years, other parameters that have been discovered and described, such as the head symphysis distance, which when 16 millimeters or less is associated with a successful vaginal delivery. I'm not going to go into too much detail about how these parameters are obtained. I'm pretty sure that the other speakers are going to go into much more detail about them, but I would like to mention the midline angle, which is a horizontal picture taken transperineally, showing the fetal head, and a perpendicular line is drawn through the symphysis pubis, and a line is drawn through the midline of the fetal head. And the angle between these two lines is called midline angle. And it's been shown that if it's less than 45 degrees, it's associated with a successful vaginal delivery. Professor Eggerbo described the transperineal head perineum distance, and it was found when less than 35 millimeters to be associated with a successful vaginal delivery. So we have all these very wonderful parameters that we can now probably combine to get a realistic photo documentation of the position of the fetal head. Another parameter that's very interesting is fetal molding. And there's a lot of research being done about the significance of this in terms of vaginal delivery and the prognosis with assisted instrumental deliveries. All of these parameters have been wonderfully brought together in the guideline published by ISWOC in 2018 by Professor Tullio Guy, and I would encourage everyone to read it. Here's a demonstration by Professor Kalash about how we perform our ultrasound in labor ward, and we start transabdominally first of all. And it's very useful here because you can very quickly identify an OP position. And also, very importantly, you can demonstrate the fetal spine if you're going to do a rotational delivery. And that's important because you don't want to turn the baby's head in the wrong direction. Translabally, as demonstrated here, we do a sagittal view translabally, where we bring the transducer against the labia, and the picture that you get demonstrates the symphysis pubis and the fetal head. And from this picture, you're able to get your parameters for the head up sign and the angle of progression. So we have all these nice parameters that we can combine to help us with the prognosis for successful vaginal deliveries.
Okay, so we have a woman in her
Here's a
first
demonstration
pregnancy with
of what we do it in
CPG is
real life.
pathological, tachycardic with decelerations. She's been 2.5 hours fully dilated, and we're now about to do the intrapartal ultrasound to help us make the decision whether to do the instrumental delivery or not. So, baby's lying in the abdomen. So we always start above, so we can see baby's lying with the back on the right. We look in the 4 quadrants. Suprapubically, you can see it's not a posterior occiput position. There are no eyes looking up. Okay, so now we know exactly how baby's lying in the abdomen. And what we're going to do now, we're just going to put the gel on. We're going to look. So that's one sagittal. So we can see immediately the head is there. We're just going to do a wing stop. We just do the angle of progression and rest. And here we have an angle of 144, so it's below spinal ulna, +2 below the spines. We turn 90 degrees. At this point we can see that the head is not fully rotated out, but we're going to do some measurements here. The head perineum distance, 3.2 centimeters, this is good. And we could also do the midline angle. Here's the midline. And we have an angle of about 40 degrees, which is also good. So very favorable. This is in rest. And now, Froti, if you could just give me a little push. Take a deep breath in. And yeah, so we can see the head up sign. Just going to freeze at this point, do another angle. So let's do one. And we can see with this position 171, so this is very favorable. We turn 90 degrees. Give me another little push. Very good. Very good. Do some more measurements. Head perineum distance, 3 centimeters. And we do T2. We do the midline angle again. And you can see the head is rotating into an occiput anterior position. 24 degrees. So these are all very good parameters. Firstly, we're going to do an instrumental delivery with the vacuum. I'm going to put a cup on baby's head. I'm going to gently help bring baby's head out when you push. Everything looks really good with the ultrasound. I'm very confident that it will work. Your epidural is working really well, so it's not going to hurt. If you have any pain, just let me know. We can give something extra. If the cup for any reason doesn't seem to be fitting well, or it pops off, it's allowed to pop off up to 2 times. We'll have to think of something else, okay? Sometimes we have to do a forceps delivery. Very, very seldom would we have to do a cesarean section if nothing works, okay? So just let me know if you have any questions. We'll get everything ready. We just need to get her leg up. Yeah. we tell the baby doctors about these sort of deliveries when we're doing them, so they're waiting outside in case baby needs any help or support. So we're just going to get the other contraction. Okay. Take a deep breath in. You're doing really well. Very good. A bit of meconium. Looking good. Oh my gosh.
Okay, so that was a pretty straightforward vacuum delivery in an occiput anterior position for fetal distress. What about complex deliveries where there's a bit of malpositioning of the fetal head, asynclitism, for example, a deflexed head or OT or OP position, where you can't put the suction cup on the flexion point? In these situations, sometimes you need to resort to a Keelan's rotational forceps. We did a study on the use of ultrasound to support the safety and performance of these sorts of complex deliveries. And what we found is that when you place the ultrasound transducer suprapubically, transversely, you can observe the application of the forceps blades and applying them correctly. And you could also document the rotation of the fetal head and the performance of the delivery. And as you can see here, we're able to visualize the forceps blades as they're being applied in an OT position. And we're also able to visualize in real time the rotation of the fetal head with the forceps blades in the right direction. So in our cohort study, we had a reduced incidence of incorrect placement, reduced neonatal trauma, and postpartum hemorrhage. There's been a sort of a renaissance in the use of Keelan's forceps in the literature, and a very large study done by Giacchino showed that of all the interventions that one can apply, the Keelan's rotational forceps in over 500 cases was shown to be associated with less adverse pregnancy outcomes in comparison to rotational ventouse and second stage cesarean sections. In terms of maternal trauma, things like levator ani muscle avulsion showed no difference between Keelan's rotational forceps and a metal vacuum. What about manual rotation? The pop-out study came out recently and it showed no significance in maternal and fetal outcomes. As a learning resource, I recommend the Royal College Strategy e-learning website, where they describe in detail all the different types of indications and performances for forceps deliveries. We do a lot of obstetric training at our hospital, simulation training, especially with instrumental deliveries, and I would encourage all units and clinics to perform this as well. And it's very important, especially for the junior doctors when they're doing their first instrumental delivery or forceps delivery, as shown here. The Royal College also came out with new guidelines, and I'm very happy to see that the ultrasound assessment of fetal head position has been mentioned, especially when there is uncertainty about the positioning of the fetal head. The technology is advancing very quickly. We now have very small ultrasound machines that you can slip in your pocket, and they're very mobile. There's a lot of work being done now about artificial intelligence and big data and helping us to identify fetal anatomy in the second stage of labor. I'd just like to quickly mention molding. We had a case recently where we had intrapartum ultrasound performed where there was a suspicion of intracranial bleeding, and we elected not to do an instrumental delivery but to do a cesarean section, and it was shown afterwards that the baby had indeed a subgaleal hematoma and a linear fracture of the occipital bone. Now, this is without an instrumental delivery. It's just because of the labor progress. So we're very happy that the ultrasound helped us in this regard to make the decision not to perform an instrumental delivery. So I think in summary, it's important to say that ultrasound is extremely useful, not only for routine vacuum deliveries, but also for complex operative forceps deliveries where you're able to identify the anatomy. You have for the first time objective photo documentation. You're able to assess the prognostic intrauterine, intrapartum, translabial ultrasound parameters, and you're able to perform the operative vaginal deliveries much more safely. It also offers an element of biofeedback for the parents because they can see the movements of the head and the pelvis on ultrasound. So please use ultrasound in labor ward, avoid the first cesarean, assess your intrapartum translabial ultrasound parameters in the second stage, encourage training, mentorship, and simulation for junior doctors and midwives. And we need to come up with concepts for developing new training for our junior doctors and midwives. And we need to standardize guidelines and consent forms for instrumental deliveries. Thank you very much, and I hope the rest of your webinar is very fruitful and useful for you.
Larry, thank you very much indeed. That was a wonderful lecture on a really important area. Just make a couple of points, and that is translabial and transperineal ultrasound, we agree, is the same thing. And just a point to the audience, if you do ultrasound prior to your assisted delivery, you will never guess where the occiput is, and you will always be able to know where to place your either forceps blades or how to place them, or your Von-Tu's cup. So I've found it just enormously empowering, actually. And Larry makes an important point about the renaissance of Keelan's forceps. I don't think I've ever had a problem or concern with Keelan's forceps, as long as you know exactly which way around the baby's head is and which way around to rotate the baby's head. Crucially, the shorter distance for the spine rather than the longer distance, which I believe is much less likely to lead to cervical spine injury. But of course, what we haven't had is a fully powered study to tell us that ultrasound in assisted delivery actually improves outcome, improves safety, because it would need to be a very large study to do that. So anyway, that's just my few points. I don't think there are any critically important questions just at the moment. We have some questions that can be answered really at the end of the webinar. So I'm going to hand over to Professor Parra. I'm very pleased to see you again, Mauro. You dropped off earlier. I hope it wasn't something I said. And you're going to say a few words in Spanish over a minute or two, just for our Spanish attendees, and then we'll move on to the next lecturer, which I will introduce.
Thank you, Christoph. Sorry for the trouble that I had with my connection. But anyway, I will make a short introduction for the Spanish-speaking people that are here. Primero, agradecer a Christoph Lies por invitarme a moderar este webinar internacional en la utilidad de la ecografía tanto como predictor de cesárea o éxito de inducción antes del inicio del trabajo parto, como su utilidad durante el trabajo parto para definir una indicación de un parto operatorio o cesárea. Los profesores que nos acompañarán esta mañana, ya escucharon a uno, son el doctor Larry Higginson, obstetra y ginecólogo de Berlín, como se señaló, quien nos habló de la utilidad de la ecografía en el parto operatorio. Luego la profesora Min Yo, del Departamento de Obstetricia de la Universidad de Corea, quien nos hablará sobre la evaluación ecográfica durante el trabajo parto para predecir el pronóstico de parto, que viene a continuación. Y la tercera charla estará a cargo del profesor Mor Egebo, profesor de medicina fetal en Noruega, quien nos hablará del por qué, cómo y cuándo hacer ultrasonido en la sala de parto. Y finalmente el profesor Andrea Dalasta, obstetra y ginecólogo del Hospital Universitario de Parma, quien hablará sobre cómo diagnosticar asinclitismo, distosia de posición y distosia de presentación en vértice a través del ultrasonido. Esa es la breve introducción. This is the brief introduction that I made in Spanish, Christoph. Hopefully that is helpful for the people that are here.
Good. No, that's really helpful to summarize a lecture after each one. So thank you very much indeed. And obviously it'll be particularly valuable for you in the questions and answer session at the end. So we're going to move straight on to Professor Minjong Oh, who is a professor in South Korea and is an expert in ultrasound and labor. She's going to talk to us about antepartum ultrasound evaluation and prediction of labor outcomes. So Minjong, over to you.
Hello everyone, my name is Minjong Oh from Korea University. It's a great honor for me to be here to present this topic. Today, I'm going to talk about pre-labor ultrasound evaluation to predict labor outcome. Ultrasound evaluation for fetal head position and station is most useful when there is slow progress or arrest of labor during the first or second stage. It can also assist in choosing between operative vaginal delivery and cesarean section in prolonged second stage of labor. Over the last decade, intrapartum ultrasound has been demonstrated its usefulness in labor management. And now there are new emerging applications of ultrasound before or during labor and postpartum associated with maternal and perinatal outcome. In this presentation, I'm going to focus on pre-labor ultrasound evaluation. I've divided my presentation into two main topics. First, I'll talk about prediction of cesarean delivery before labor, and second, I'll tell you about prediction of successful induction of labor. I'd like to begin with sharing my case that could cover my entire talk. She was a 40-year-old nulliparous woman. She got pregnant with IVF procedure. She was admitted 39 weeks of gestation for labor induction. On the second day of induction, she finally reached full dilatation of cervix, but AOP was 140 with severe caput formation, and her baby was in OP position. Fetal head movement was hardly seen with maternal pushing, so we decided to perform cesarean delivery instead of trying vacuum delivery. The baby out was very difficult due to the deeply impacted head, and she needed blood transfusion during the operation. You all have probably experienced this, and this is the very frustrating situation for women and obstetricians both. Like this, many nulliparous women need unplanned operative delivery during labor. And we know that unplanned operative delivery is associated with adverse maternal and neonatal outcomes. Therefore, pre-labor identification of a patient at high risk for unplanned operative delivery is necessary for safe childbirth. This is a prospective study of 2,336 of nulliparous women between 39 plus 0 and 40 plus 6 weeks of gestation to predict unplanned cesarean delivery before the onset of labor using maternal and fetal, anthropomorphic, clinical, and ultrasound features. 5 parameters were determined to be the best combined predictors of cesarean delivery, which were advancing maternal age, shoulder maternal height, increasing BMI, larger fetal head circumference, and larger fetal abdominal circumference. Using these parameters, a nomogram was developed to provide an individualized risk assessment to predict cesarean delivery before labor. The area under the curve was 0.69, and the misclassification rate was 21%. However, in this study, only fetal sonographic parameters such as head circumference and abdominal circumference were used. But additional parameters of maternal-fetal interface like head-perineum distance or angle of progression to the risk assessment could improve the accuracy of the prediction model. In 2012, this study investigated if angle of progression can predict mode of delivery before onset of labor. It showed the median AOP measured before onset of labor was significantly narrower in women who went on to deliver by cesarean section than in those who delivered vaginally. An angle of progression greater than 95 degrees had a sensitivity of 85% for the prediction of vaginal delivery. This study did not assess the patient before labor, but on admission in active labor. It also showed head perineum distance and angle of progression at admission were associated with a spontaneous delivery with AUC of 0.68 and 0.67 with the best cutoff levels of less than 45 millimeters and greater than 93 degrees respectively. However, it seems that we also need to consider the sonographic parameters representing maternal pelvis. Interspinous diameter and obstetric conjugate diameter are non-measurable landmarks of the pelvis with ultrasound. But we can measure pubic arch angle with ultrasound, and there is a significant positive correlation between pubic arch angle and interspinous diameter, and between pubic arch angle and obstetric conjugate diameter. This correlation may serve as a basis for prognostic value of pubic arch angle for a safe vaginal delivery. In 2016, Dr. Youssef's group made a 3D sonographic assessment of subpubic arch angle before onset of labor to predict labor outcome. The subpubic arch angle appeared to be significantly narrower in the women submit to obstetric intervention compared with those undergoing spontaneous vaginal delivery. In multivariate analysis, subpubic arch angle and maternal age were identified as independent predictors of the mode of delivery. This year, a prospective study that includes all sonographic variables that I have mentioned thus far has been published. In this study, the authors have developed a prediction model using sonographic measurement of estimated fetal weight, maternal pubic arch angle, and angle of progression with maternal characteristics. They measured pubic arch angle in 2D image. With a transversely positioned transducer, an angle is created at the inferior borders of pubic rami that converge at the middle of the pubic symphysis. The best model with an AUC of 0.7118 included maternal age and height, sonographic pubic arch angle, angle of progression, and estimated fetal weight. Then, is there any other sonographic parameters that we need to consider? The fetal parameters and maternal pelvis parameters are absolute values, but we also need parameters in maternal-fetal interface to see the relative relationship between the two. Head perineum distance or angle of progression can be one of those parameters. And now, I'd like to suggest another sonographic parameters in maternal-fetal interface. As you already know, posterior cervical angle is the angle between the cervical canal and the posterior uterine wall. It has been proposed as a more accurate reflection of the position of the cervix, which is a component of the Bishop score. Recently, one of my colleagues, Dr. Ho-Yeon Kim, examined the value of the cervical markers, including posterior cervical angle, in the prediction of successful vaginal delivery before onset of labor. Cervical length was significantly shorter, and posterior cervical angle was also quite significantly wider in the vaginal delivery group compared with the emergency cesarean section group. Logistic regression analysis revealed higher maternal BMI, multiparity, and posterior cervical angle 96.5 degree or more were independent factors associated with a successful vaginal delivery. The relationship between the cervical canal, internal os, and uterine wall might be one of the essential factors related to labor progression. A wider PCA leads to easier passage of the baby through the birth canal, while a narrow PCA would lead to less direct force on the internal os, causing difficult labor progression. If we can make a prediction model that enables us to predict the possibility of unplanned operative delivery more accurately, it may assist in deciding the optimal mode of delivery for the specific patient before onset of labor. At present, we must rely on a trial of labor to determine if labor can be successful in effecting vaginal delivery. However, with the development of ultrasound technology and the experience of intrapartum sonography in labor management, there are some possibilities to objectively diagnose fetal-pelvic disproportion. If obstetricians could predict which women will need an operative delivery before onset of labor, increased risk might be avoided by offering an elective procedure to those at greatest risk, whereas those at low risk could be reassured and encouraged to try a vaginal delivery. Now let's move on to my next topic, prediction of successful induction of labor. Induction of labor is one of the most common interventions in modern obstetrics, and its frequency is expected to continue to increase. It is known that about 15 to 20% of induction of labor fail and end in emergency cesarean section. Professor Nicolai's group already examined the value of pre-induction sonographic assessment 20 years ago in the prediction of successful induction of labor. According to this study, prediction of likelihood of vaginal delivery within 24 hours and cesarean section was provided by pre-induction cervical length, occipital position, posterior cervical angle, and maternal characteristics. In the prediction of vaginal delivery within 24 hours, the sensitivity of ultrasound findings plus maternal characteristics was 89%. And in the prediction of likelihood of cesarean section, the sensitivity was 78%. By the way, few years ago, we investigated the use of the angle of progression to predict spontaneous onset of labor within 7 days. This study included 96 nulliparous women. The angle of progression was higher in women who underwent spontaneous onset of labor within 7 days than in those who did not. And logist regression analysis showed that a larger AOP was an independent predictor of spontaneous labor within 7 days. This finding supports adding AOP to pre-induction sonographic assessment can improve the accuracy of a prediction model for labor induction outcome. In fact, in 2008, Dr. Ejebo's study has already shown that before induction of labor, fetal head perineum distance could predict vaginal delivery with a predictive value similar to that of cervical length and the Bishop score. However, at that time, they concluded that none of these methods used alone to be good enough to be used in a clinical setting. Recently, this study assessed the feasibility of the model for the prediction of cesarean section for failure to progress as an outcome of labor induction. Among the variables they analyzed in the study, the angle of progression was found to be one of the reliable independent predictors for the success of induction of labor. However, although several studies have shown that these sonographic measurements are superior to digital assessment, their predictive values remained suboptimal for clinical use. One main reason for this is that using conventional ultrasound technology, we cannot measure cervical consistency, which is a major component of Bishop score. This excellent study evaluated the predictive value of cervical shear wave elastography to measure cervical consistency in the outcome of labor induction. Shear wave elastography uses ultrasound pulses to generate shear wave across the target tissue, and the shear wave velocity correlates to the tissue stiffness. In this study, shear wave elastography measurement was made at the inner, middle, and outer regions of the cervix to assess homogeneity, and they found out the stiffness of the cervix decreases towards the outer cervix. So they used the inner cervical SWE for analysis. There is inconsistency as to how failed induction of labor is defined. The majority of studies define success as the achievement of vaginal delivery, especially within 24 hours. However, in this study, 3 subgroup analyses were performed: cesarean for failure to enter active phase, cesarean for failure to progress in active phase, and cesarean for fetal distress. Compared with the vaginal delivery group, women who had a cesarean section for failure to enter active phase had a significantly higher inner cervical SWE value, as well as a longer cervix, smaller PCA, and smaller AOP. However, all of these sonographic parameters are not useful in predicting cesarean section for failure to progress or fetal distress. This finding is biologically understandable because fetal distress is unrelated to cervical favorability, but rather restricted fetal growth and fetal compromise, whereas failure to progress is related more to large fetal size, as you can see here. The outcome of prediction models based on inner cervical shear wave elastography and cervical length showed higher predictive accuracy to predict failure to enter active phase. And they further focused on the nullipair subgroup. Sonographic prediction was even stronger than Bishop score. There is another study using strain elastography. Strain elastography is based on the measurement of tissue displacement under compression, either extrinsic or intrinsic. It is based on the principle that soft parts of the tissue deform more than harder parts under compression. This system uses minute internal organ movements, including vessel pulsation and respiratory movement, as compression sources. In this study, they used semi-automatic program which evaluated the whole cervix as a region of interest and analyzes the heterogeneity of the entire cervix via multiple parameters related to cervical stiffness. They compared the result between women who delivered vaginally within 24 hours and those who delivered after 24 hours. Among the parameters of elastography, the hardness ratio and mean strain levels of the internal os was significantly different between the two groups. This year, we presented the prediction value of cervical strain elastography in the outcome of labor induction. We define the primary outcome as whether or not to enter the active phase within 12 hours after oxytocin infusion. The AUC of cervical length, PCA, AOP, and maternal characteristics was 0.837. When strain elastography values were added, the AUC goes up to 0.865. Although our study included a small number of patients, cervical elastography, shear wave or strain elastography both, seems to be a promising tool for predicting a successful induction of labor. In summary, intrapartum ultrasound has demonstrated its usefulness in labor management. Accumulated knowledge from intrapartum ultrasound can be applied to antepartum period when a woman is expecting to deliver her baby. It may help us to decide on the optimal mode of delivery for the specific patient before onset of labor and predict successful induction of labor. Thank you for your attention.
Thank you very much indeed for that extremely comprehensive overview of prediction of labour outcome. I think there are a few questions, so we'll no doubt come back to those later. Thank you, Professor O. We move straight on to Professor Igebo from Stavanger and Trondheim in Norway. I think Trondheim, rather than Stavanger. But Torbjørn, as you saw from Professor O's lecture, and I think Larry Hinkson mentioned as well, is one of the pioneers of intrapartum ultrasound, particularly head perineum distance and some of the other measurements we use. He is going to talk to us. He's going to make it easy for us. He's going to talk to us about how we use the techniques, mastering the techniques. Over to you, Torbjørn. Sorry, no, Mauro, you're going to do a short intro, aren't you, to Torbjørn? Is that right? Oh, you're going to, I'm so sorry. I've got this in the wrong order, my fault. You're going to summarize Professor O's lecture and then we'll move to Torbjørn. Is that correct?
Yeah,
am I right on that? Yeah.
So
Yeah, okay. Apologies for that.
Brief summary of the Professor Min-Yo Ho in Spanish. That's my duty now. So I will summarize that. El objetivo de esta segunda charla que ustedes acaban de escuchar de la profesora Min-Yo Ho fue básicamente determinar la utilidad de modelos multivariados, incluida la ecografía intraparto, para predecir cesáreas no planificadas durante el trabajo parto y el éxito de la inducción del trabajo parto. El riesgo de tener una cesárea no planificada durante el trabajo parto está dado por un modelo multivariado que incluye esencialmente, primero, variables fetales como la posición fetal, circunferencia craneana, circunferencia abdominal y la estimación de peso fetal. Dos, lo que ella llama interfase materno-fetal, donde está incluido el ángulo de progresión, la distancia perineo-cabeza y el ángulo cervical posterior. Y tres, aspectos relacionados con la pelvis materna, muy interesante, un ángulo que se mide que se llama ángulo subpúbico materno. Por otro lado, la segunda parte de su charla fue básicamente modelos predictores del éxito de la inducción, que incluyen variables clínicas y ecográficas del feto, cervix, medición del cervix y otras formas de evaluar cervix y pelvis, pero aún ella señala con baja capacidad de predicción. Recientemente, ella señala que se han incorporado estos modelos predictores la medición de la consistencia y distensibilidad, o lo que se llama en inglés strain, del cervix por elastografía, generando mejores capacidades predictivas como ella señaló. Ready, Christoph. I have just done the brief summary of the second lecture.
Excellent. Thank you very much indeed, Mauro, and sorry for going slightly out of order. Now, we move over to Torbjørn for a lecture on the techniques and mastering the techniques.
First of all, I would like to thank you for inviting me to this event. And it's a pleasure to present for you ultrasound in the labor room, why, how, and when. Why? Because clinical assessment of position is inaccurate, and Akmal and her group found that digital examination during instrumental delivery failed to identify the correct fetal head position in about 1/4 of cases. And the clinical assessment of descent is also subjective. And Dupuy from France used a birth simulator and found that numerical errors occurred in 36 to 88%, and the undiagnosed high stations accounted for 20% of errors. Knowledge about the labor mechanics is important. It's important for understanding the labor progress, and it is important in decision making. Every day we have to decide, should we do a cesarean, a vacuum, or forceps delivery, or perhaps should we just wait and observe? There is an underuse of assisted vaginal birth in many countries. In the United Kingdom and Scandinavian countries, more than 10% of women are delivered with operative deliveries. However, in low and mid-resource countries, less than 1% are delivered by an assisted vaginal birth. The assisted vaginal birth can reduce the rate of cesarean deliveries, has pediatric and maternal benefits of a vaginal birth, and has the potential to improve maternal and newborn outcomes in special low-resource settings. You can use ultrasound to train your clinical skills because you can do a clinical examination first and check with ultrasound if you were correct or not. Ultrasound has benefits for the mother. It can reduce the risk of infection by reducing the number of vaginal examinations, and is less uncomfortable for the woman compared with clinical examinations. How to do the scans? First of all, the principal fetal movements are rotation, descent, and flexion and extension. Some definitions: the lie can be longitudinal, transverse, or oblique. The presentation is the lowermost part of the fetus in the birth canal and can be breech, occiput, sinciput, brow, or face. And the position is the rotation of the fetal head. And the attitude is flexion or deflection. I always start with the transabdominal scanning, and I try to do this in a structured way, starting with a transverse scan, moving around the maternal abdomen, paying special attention to the area below the symphysis pubis, turning transducer in a longitudinal way, first in the midline, then on the left side, and on the right side now. After this, I will show you a video clip for about 1 minute. Try to observe as much as possible, and I will be quiet during this video. even with little training in ultrasound in active labor, I suppose you had a lot of information from this video. Please answer the questions. What was the fetal heart rate? Could you see the placenta? Could you see the amniotic fluid still present or not? What was the fetal lie? Position of head and spine? What was the attitude? And what was the fetal presentation? The fetal heart rate was normal, around 150. Placenta anterior right. Still amniotic fluid present. It was a longitudinal lie. Occiput posterior position with occiput at 5 o'clock. You could see the fetal eyes and the nose at 11. The spine was at the same position.